So as Shannon said, we're going to be talking about the pregnancy and the COVID-19 vaccines today. If you guys have questions at any point during the presentations, feel free to throw them in the chat or do the little raise hand thing, although I don't know if I can see that, but I think Shannon can pause me. All right. So the contents of the talk today, we're going to talk a little bit about the current state of affairs, why the COVID vaccine in pregnancy matters, how the vaccine works. So hopefully everybody's a little bit better equipped to talk about some of the questions about the mechanism that we often get, the vaccine safety profile, and then a couple of thoughts about how we're talking to patients about this vaccine in pregnancy, and then sort of next steps. So a quick personal story, as Shannon mentioned, my beautiful daughter Ellie was born in March of 2021. So I was pregnant from the summer of 2020, that first summer of the pandemic, through early 2021. And so was pregnant in the second trimester during the development of the vaccines. So in December of 2020, I was late second trimester pregnant and was offered the Pfizer vaccine through work at UVA. I was not familiar with mRNA vaccines, the mechanism, how they worked, if they should be approved in pregnancy. No pregnant people were included in the studies, unfortunately. And so I hedged. So I absolutely understand the patient perspective of, I don't know enough, and this is scary. And I think for so many moms out there and pregnant people, the first instinct is protect the pregnancy, protect this baby. And oftentimes that protection instinct goes to inaction rather than action, because the status quo seems safer than choosing and actively choosing something that could potentially harm. During the last few weeks of December, I did a lot of reading. I read a lot about the mechanism of mRNA vaccines and the few mRNA vaccines that had been developed, like Ebola, which hadn't been prominent here in the US. Thankfully, we didn't have much Ebola, but that had been studied on some pregnant women in other countries. And when I couldn't come up with a way that it could harm my pregnancy and it seemed very safe to me, I escalated it and talked to some of the smartest people I know in high risk obstetrics and MFM, and none of them could come up with a way it could hurt my pregnancy. And so in early January of 2021, I was vaccinated, or we were vaccinated, Ellie and I were vaccinated against COVID-19. And being able to very personally talk about understanding that waffling, that equivocation, and that desire, the innate human desire to stay at the status quo if you're unsure about something, I think I can very much understand with these pregnant moms. And so I start a lot of my conversations with them from a place of empathy, and I think it kind of cracks open the door of some of the really resistant patients a little bit. But we'll come back around to that at the end when we're talking about how to talk to people about it. But first, let's just talk about where we're at with COVID. I think in terms of COVID, we're at this transition point where we're hopefully soon going to be transitioning from pandemic to endemic. And endemic is things like the flu. It's here every year. It doesn't go away, but it's not enough that it's overwhelming hospitals and it's controlling our society, and it needs to be protected on every level. It's something that most of us get an annual vaccine for, and we don't think much more about. And so the hope is that sooner or later, we're going to hit enough vaccination and innate immunity for COVID that the incidence will drastically decrease, and we will simply be in an endemic state where it lives around us but doesn't control us and doesn't overwhelm our hospital systems. Why does that matter? Because at the beginning of the pandemic, your choices was just to be cautious and isolate. As the vaccine became available, we started having this choice of being cautiously well, masking, social distancing, going out only when needed, versus being vaccinated. And I think a lot of my patients were like, I'm remote work, I'm staying home, I don't need to be vaccinated because I'm just going to limit my exposures and thus my risk. As we've now transitioned to more, as the pandemic has evolved, and while we're masking and doing these things, you can't do that forever and isolate forever. The choice is really transitioning, and this is sort of how I frame my conversations with people. The choices are now becoming sick with COVID and developing your own innate immunity versus getting vaccinated. And it's not that you can't get sick with COVID when you're vaccinated. We all know you can, but the emphasis being you don't get sick, you don't get hospitalized, you don't get intubated, you don't get ECMO, you don't get those bad things nearly as often if you're vaccinated. And so people are like, nope, I've survived it this far, I don't need it. And I think the transition point, the choices are really boiling down to get vaccinated or develop your own innate immunity, which is, I think, the harder course of action for many women. And this is a cartoon from the New York Times that I think illustrates very well. I think a lot of unvaccinated patients say, well, you can still get COVID if you're vaccinated, and you can, but it gives you this armor and it gives you a much better fighting chance to avoid that severe illness. And now we have some good data that shows when you're vaccinated, while you can get COVID, you're less transmissible, you're less contagious, you clear your virus faster, and you have a lower viral load. So better for those around you also if you do happen to get COVID, compared to those who are fully unvaccinated and need a lot more time to build that innate immunity and thus can get a lot sicker with COVID. So let's talk about specifically pregnancy. So COVID and pregnancy in the US. The CDC just came out with a new update that says about 40% of pregnant women as of January 1st of this year are vaccinated against COVID, only 40%. So we're still at far less than half. There's been the rest of these stats, I think, are a little bit questionable. They're probably grossly underreported in the US because of our limited ability to have sort of a national monitoring system. This is all hospital-based reporting to the CDC, so it's probably a little bit more limited than other countries that have a centralized monitoring system and a universal healthcare. We've had about 158,000 confirmed cases in pregnancy that have been reported to the CDC, 26,000 COVID-positive pregnant hospitalizations that are hospitalized for COVID, and 259 deaths directly resulting from COVID in pregnant women, the peak of which was in August of 2021 during the Delta predominance. And it was a terrible month in which we had over 40 maternal deaths. Risks for severe COVID. So I'm sure, as you all know at this point, pregnancy alone is a huge risk factor for severe COVID. Compared to their non-pregnant counterparts of similar ages and comorbidities, they're about twice as likely to have severe disease and not even more likely to be, intubated or admitted to the ICU. So pregnancy, and then all the other things that go into severe COVID not pregnant. Elevated BMI. Over a third of our pregnant women in Virginia have an elevated pre-pregnancy BMI. And so then typically only gaining weight in pregnancy as well, typically having worse airways in pregnancy just because of the natural course of pregnancy and the natural edema that occurs. Hypertension, diabetes, smoking, pre-existing pulmonary diseases like asthma, and any immunocompromised state, which we think pregnancy probably is, also picks up on a little bit of that as people's immune responses are not quite as strong in pregnancy. So pregnancy alone is one risk factor, but most of our pregnant patients that we're seeing these days have at least one of these other ones as well. So they're a setup for pretty severe disease, which just increases the need for these vaccinations in this population. The risks of COVID in pregnancy. Some of the biggest risks I think of are not actually for mom. They're premature birth and they're stillbirth and IUFD or peripartum death. And these are the ones that I think actually get through to mom a little bit more often than some of the maternal risks. There's been some good studies that actually link COVID to hypertensive disorders in pregnancy. So gestational hypertension, preeclampsia help the whole spectrum of hypertensive diseases in pregnancy. Certainly increases your risk of hospitalization, intubation, ECMO, and death, maternal death as well. So all things that we know are significantly increased by just having COVID, and that goes even for mild COVID disease, has been associated with several of these things. And it makes sense that it's probably on a dose response. The sicker you get with COVID, the more likely you are to develop these things, but even mild disease can predispose you more than your baseline. Longer problems with COVID, not just related to pregnancy, but people are at risk for long COVID. That's a whole different talk. And then there's been some newer papers that actually show an increased risk of developing diabetes. So type 1 and type 2 diabetes. Hasn't been directly studied to show if early pregnancy COVID may predispose you to gestational diabetes as well, but it would make sense by the mechanism that might also be there. And that diabetes risk is for diagnosis within about a month of your diagnosis of COVID, that increased risk of type 1 and type 2 diabetes. And then prolonged lung problems related to the pulmonary damage from COVID itself. So one really nice, exciting new study that was published actually within the last week that I think gives us a lot more leverage in terms of talking to patients and talking to moms about this, looks at population level data from Scotland. And this is one of the first really big, everybody's included retrospective cohort studies from a country that has a universal healthcare system. So theoretically, they're capturing everybody who is willing to get tested. So, and unvaccinated, of the pregnant patients, unvaccinated pregnant people, had 77.4% of COVID infections, so symptomatic. They weren't really testing many asymptomatic patients in Scotland at the time, but of symptomatic COVID infections. Over 90% of the hospitalizations, and I forgot to mention, this is, so unvaccinated, they include partially vaccinated in this in the vaccinated group. So partially vaccinated was not considered unvaccinated, unlike many of the studies done in the US. So purely unvaccinated comprised 90.9% of the hospitalizations, 98% of the intensive care admissions, and then all 450 fetal and neonatal deaths associated with COVID. They were all in the unvaccinated group, which is just, I think, a profound statistic that all of them were unvaccinated, which is sad. And so one of the big things that came out of this was an increased perinatal death rate. So both IUFD stillbirth as well as within the first 28 days, neonatal mortality in the first 28 days, the perinatal death rate rose to 22.6 in unvaccinated women who got COVID in pregnancy, compared to a background rate of 5.6 per thousand. So about a 4 times increase in the rate of perinatal death. And this is important because I think there's a lot of maternal hesitation around potentially harming a pregnancy. And there's not a lot of maternal concern for themselves. Obviously, I think pregnancy makes a lot of women feel very selfless towards the pregnancy, and I will sacrifice myself for the pregnancy. But if we can start to show and really talk about the benefits for baby, I think it's our way in the door in terms of vaccination rates for a lot of these women. Are thinking about our uptake rates for Tdap, because it's a vaccine for baby, are better at times than our vaccination rates for influenza, because that one's more for mom. And so I think being able to have good data behind the benefits for baby is going to be an important framing for increasing our vaccination rates. All right. A little bit about the risks of the vaccine, fairly minimal and not really going to change in your pregnant and your non-pregnant populations. The main risks, fevers, chills, muscle aches, and that local erythematous, red bullseye reaction that some people are getting. And for pregnant women, I joke and I'm like, yeah, the only thing that really bothered me is you're a side sleeper when you're pregnant. And so every time I'd roll to that side, it would wake me up and I'd have to roll back to the other side. That was really the most obnoxious part. What we know is not associated. So many studies at this point have showed it is not associated with miscarriage, even in the first trimester. It's not been associated with any birth defects in large cohort studies. The largest one I think was over 40,000 women they looked at, no associations with miscarriage or birth defects, and not associated with preterm birth. Some of the studies show the reverse. Because the COVID itself is so associated with preterm birth, the vaccines have been associated with a decrease potentially in preterm birth. Let's talk a little bit about how it works. This is one of the primary questions we get about the vaccine, is that people think it's going to alter their DNA, or all of those wonderful Twitter type conspiracy theories out there. So there's 2 types, and they have different mechanisms. There's the mRNA vaccines, Moderna and Pfizer. They work very similarly. And then there's the viral vector, which is the J&J, and in some other countries, AstraZeneca, and there's a few others. And so we'll split them out and talk about them a little bit separately. So this is a great graphic put out by Moderna, but this summarizes both the Moderna and the Pfizer vaccine. So you get injected with the mRNA, which is simply the building blocks for making a protein molecule. Your cells uptake this encoded mRNA, and something called the ribosome within the cytoplasm of the cell transcribes this into a protein. The protein can then be expressed onto the outer surface of this type of cell, and the cell presents it to the immune cells in the body and say, hey, I found a new invader. Those cells, primarily your T cells and your B cells over here, come and look at that antigen, that protein, and say, okay, this is our invader. We're going to make a copy of this. We're going to be able to recognize it quickly, and we're going to be able to attack if it ever comes in again. And so you make both T cell and B cell immunity and early recognition systems for any of these proteins. And these are typically the S spike protein that everybody's heard about, I think, in the media. The T cell immunity is sort of more innate immunity. The B cell immunity is what we're measuring when people are looking more often at their antibodies and things. And so these then translate into some type of longer term immunity. With some diseases, measles, mumps, rubella, things like that, you only need one series in your lifetime and you're done. With other viruses, we need multiple, like think about the flu, an annual vaccine, in part because of the rapid mutations, just like we've seen with COVID, and in part because of waning immunity, because even though you can recognize it if it comes in, you might not recognize it as quickly as you need to prevent severe disease just because of how aggressive the virus is. And so that's what we're seeing with COVID is it's going to end up being probably more like influenza. We're probably going to need annual boosters, both to keep up with the mutations and also to keep our immune system ready to really fight, to really avoid the severe disease, just because of how severe it is as a virus. It's very aggressive and very, very virulent. So that is the mRNA vaccines. All of this is degraded within your body by 10 to 20 days out. The mRNA degrades more quickly, but then the proteins you've already created can last. The longest they've seen them is about 20 days out. So people who are worried it's going to stay there forever, it's going to create some issue. It's really not. It also really just stays local. Most of this is not taken up by your body. This reaction, all that you're seeing here, is done quite locally in your muscle. And so these viral proteins are not going to your baby. The antibodies you make can go to your baby, but the viral proteins are not going to your baby. The mRNA is not going to your baby. None of those things. Those are common questions that we get. The viral vector, or the J&J vaccine. So this is an adenovirus viral vector. So it uses the shell of the adenovirus to get that mRNA and that protein building blocks into our system. This is the same way the flu vaccines have been developed for years. They build this adenovirus vector in part via egg incubation, which is why people typically couldn't get the flu vaccine with egg allergies. Now moving away from that in some of our newer technology, but those are all sort of similar concerns I've had people have had about the J&J vaccine. So this is sort of the CDC's image about the viral vector vaccines. The viral vector the virus is used as a vector simply to deliver the information into your body. The vaccine does not contain any live virus. Again, it's just the protein building blocks. And then a similar thing happens. Once you get the building blocks in, that mechanism is still the same in sort of transcription of the protein, presentation of the protein to your immune system, and then recognition by your immune system to then create that lasting immunity. Vaccine safety concerns. So VSafe, the vaccine checker by the CDC, has been monitoring as sort of everybody who's willing to sign up. We've had over 150 pregnant women or signal that they were pregnant when they do their VSafe, and then a smaller portion of those have signed up to be followed as part of a cohort and volunteered to be contacted again regarding their pregnancy outcomes and those things. And so the cohort data is, I think, 20,000. It's much smaller than the amount of pregnant women who have said they were pregnant but aren't willing to be followed, which is understandable. But the DART data is the animal studies that are done prior to even the emergency use authorization of these vaccines. So the DART data showed no impact on reproduction in the animal models, which is always promising. The cohort studies thus far have shown no associations with any adverse pregnancy outcomes. The largest one of which was recently published followed over 40,000 pregnancies from positive pregnancy test through pregnancy outcome, including early spontaneous losses, ectopic pregnancies, preterm deliveries, all of the things that can happen in a pregnancy, and looked at a composite outcome of like perinatal adverse outcomes. Hasn't been associated with anything. They particularly looked at preterm birth, which was not associated with either of the vaccines, small for gestational age, which was not associated, and then their composite outcome was also not associated. So all of the data we have thus far, as well as the theoretical mechanisms, are not showing any negative outcomes in pregnancy. There was, for a little while, there's a warning on J&J about the blood clots. And so with pregnancy being a hypercoagulable state, there was some concern about J&J in pregnancy possibly increasing your risk of blood clot. Nothing's been borne out in the data, but if people are worried about it, if that's a concern, go with an mRNA. That's fine. There's very few contraindications to mRNA vaccines, which is great. Vaccine benefits to baby, and this is one that I often highlight for patients who are on the fence. There are some studies now showing that lower risk of preterm delivery simply because COVID is increasing the risk of preterm delivery. Depending on the incidence of COVID in your state, it either washes out to equal or it could even reduce the risk a little bit. This potentially lower rate of perinatal death compared to getting COVID if you're unvaccinated. And then the antibodies. The antibodies were a big one for me. I was very excited to be able to protect my little one from COVID during her, very susceptible first 6 months where they just can't protect their respiratory system at all. And those antibodies, they've been followed several, bunch of cohorts of babies serially, and the antibodies seem to be lasting at least 6 months, which is great. And then you can pass additional antibodies through your breast milk if you're choosing to breastfeed. Let's talk about the contraindications, because lots of people come up with lots of contraindications to the COVID vaccines. True true contraindications include anaphylactic allergies to PEG, which is polyethylene glycol, Miralax. Prior to COVID, I think I remember one person who had a PEG or polyethylene glycol on their allergy list because I thought it was so odd to be allergic to Miralax. Not anaphylactic, and then since then, many people have tried to add it to their allergy list. It is in the mix for the mRNA vaccine. So if you have a true anaphylactic reaction to polyethylene glycol, that is a contraindication to the mRNA. Great, get the J&J vaccine. Very few people have true contraindications to both. Anaphylaxis to the flu vaccine is a concern for some people getting the J&J vaccine because they have similar viral vectors. That being said, there have been some studies that show the true crossover is very low, closer to 10%. And so plenty of people who are allergic to the flu vaccine can still get the J&J. What I've been telling people is if they have an allergy that they're super concerned about, there's a bunch of allergy groups around who are willing to do the vaccines in their allergy clinics where they can appropriately handle an anaphylactic reaction. They're allergists. And a lot of them are very willing to do that to try and increase our vaccination rates, which is great. The real main contraindication is going to be a severe reaction to number one. So if you get an mRNA vaccine and you have an anaphylactic reaction or something close to that, then that is the most commonly cited reason not to get a second one. That's okay. Get a J&J. Then you can be fully vaccinated, but without completing that mRNA series. And then a history of myocarditis with vaccine one is a reason potentially not to get the second. It depends on the severity of the myocarditis, your risk for severe disease. In this case, we're just saying talk with your cardiologist. Most of people have a cardiologist at that point if they had true myocarditis. And talk with the cardiologist. A lot of the cardiologists are just recommending a switch to a different vaccine, but there doesn't seem to be quite as much consensus in that situation. Honestly, the myocarditis, I don't think I've yet seen it in a woman of reproductive age. It tends to be more common in men. So hopefully is not going to be much of a problem in our population. Things that are not a contraindication, history of GBS or Guillain-Barré, not a contraindication to the mRNA vaccines, and egg allergies, not a contraindication to either, but if people are worried, I'm like, all right, just get an mRNA. There's absolutely no egg component in mRNA at all, and there's no similarity to a flu vaccine if they're worried about that similarity there. And if you're still worried, get your vaccine at an allergy clinic where they're offering those special vaccine clinics. And that way you can be monitored. They do serial blood pressures, they check for all the things, or pre-medicate them with Benadryl if they're really worried about it. All right, and so COVID vaccines are officially recommended by almost all major organizations in the US, the Society of Maternal Fetal Medicine, SMFM, the American College of Obstetrics and Gynecology, ACOG, the American Society of Reproductive Medicine, ASRM. This one's important because you'll also have patients come to you who say, I want to get pregnant, or we're trying to get pregnant, and I don't think I should get a vaccine because I've heard about infertility issues. And so a quick aside about that. Infertility issues and the threat thereof have been a huge card in the anti-vax game. That was the number one scare tactic they used when the HPV vaccines came out. Is there was all this media about how it was going to make you infertile. There was never any biologic plausibility to that. No, none of the doctors I have ever spoken to actually thought that that was true. But it takes a while to disprove it. And so there's just enough uncertainty around it that if you don't understand advanced biology and the mechanisms of these vaccines, it's scary. And I think fertility in particular is super personal, and it just makes people want to do absolutely nothing. What we have seen is a decrease in fertility in men, at least following a COVID infection, and no decrease in men's fertility after the COVID vaccine. So in men in particular, we can definitely say that the data is suggesting that, in fact, COVID is far worse for fertility, and I suspect the same is for women. There's no mechanism by which I can come up with that the vaccine could hurt your fertility, but certainly COVID can cause all sorts of long-term issues with your body, which could put you in a place that makes it much more difficult to get pregnant in the future if you have severe illness, at least. And now the CDC, we won't make jokes about how much people care about them right now, but they recommend it, and so does the WHO now. All right, so let's talk a little bit about talking to patients and sort of how to come about this, because I think at this point, almost everybody who walks into our offices or who we see in the hospital has a very clear idea of whether or not they want to get this vaccine. And so there's a lot of preconceived notions around it. And I think it's getting to be a harder and harder conversation to start. it's no longer that people don't know, and now it's more often that they've made up their mind one way or another, and sometimes not with the best information. So I tend to start all these conversations with very open-ended questions. Do you have any concerns about it? What are your thoughts about it? What have you heard that worries you? And trying to get them to talk to me about highlighting anything that's sort of their biggest barrier. And usually they'll tell you in the first, few lines what their biggest concern is. For a while it was, the government is pushing it. I don't want that. It's going to make me infertile. It's going to hurt the baby, all those things. And once they have a chance to vent, oftentimes they're a little bit more willing to listen. And so I usually try a combination of that and motivational interviewing, asking sort of, okay, so what kind of things would you need to know to feel safe with this vaccine? What are the gaps in knowledge? What can I help educate you about that would make you think about it a little bit more, even if you're not going to commit to me that like, this would make me get it. This would make me think about it or consider it. And then slowly trying to step my way towards that. I try really hard. I think it's really easy because we see all the bad things, because every time I'm on call lately, there's at least 3 intubated COVID patients who are pregnant. And, last time I got there, they were just finishing a section on a 27-weeker with COVID. And you're just like, it's so easy to think about the negative. I try really hard to focus on the positive. What we know about people and decision-making in stressful situations is that scare tactics don't work. And so me telling her you could be intubated, you could get ECMO, you get all these things, it's not going to help. And for the most part, that just shuts people down. So I try really hard to focus on the positives, to talk about protecting baby and to think about this decision as a decision that will help protect baby and will help protect you so that you can be around and be healthy to be a mom to this new baby. And at the end of it, regardless of whatever their decision is, regardless of how receptive they are to it, I say, okay, at the end of all that, I just really need to tell you that it is my medical recommendation that you get this vaccine in pregnancy. And so that they know unequivocally, they cannot pretend I did not tell them, it is my medical recommendation that you get this vaccine. I understand you're really resistant. I just encourage you to think about it. And that's all we need to say about it today. And then come back at any point with additional questions. And I always say, my chart me, call the office, whatever. I'm happy to talk to people about it. I'm happy to talk more, but at the same time, if they're not receptive, I try not to push it too far and completely shut them down. I also write it down. I put it in their AVS so they can take it home and they could share it with their partner and maybe start that dialogue. Maybe it's the partner who really doesn't want them to get it. And so they can kind of start that dialogue and also have it in writing that, like, in black and white, this is medically recommended in pregnancy. It's a very low conversion rate. And there are days where I am incredibly disheartened by having these 30-minute conversations in my 10-minute prenatal appointments and not making anybody budge an inch. But I just have to focus and celebrate on the wins. And each person you convince may be the one who was going to be hospitalized and intubated, and you may have just saved one person a very traumatic event. And then I try to remember that as we have an ongoing relationship, as I see people more and more and they begin to trust me more, trying to figure out the right times to delve back into it. Or sometimes I think, all right, fine, you're not willing to right now. Let's talk about your partner. Let's talk about building a safety sort of net around you and baby to reduce the risk that you get it, at least, if you're not willing to actually get the vaccine right now. And while you're thinking about it, then they watch their partner go through it. And then sometimes they're more open to it when they know somebody personally who has actually gotten the vaccine. The little graphic down on the side is just motivational interviewing. So green part, you're starting with open-ended questions. Orange, you're affirming what they've said and kind of reflecting on what they've said and trying to make the next step. You summarize what they said and you move forward with the next question as you sort of help them make their goals and make their step towards whatever the outcome is that you guys have jointly decided upon. So just to quickly review the benefits of vaccination as I talk to moms about them. Pregnancy, the biggest thing is just decreasing the chance of severe illness. And I try to be very open about it. I'm not going to say it's going to prevent you from getting COVID. It's not true. And they're going to know that it's not true. It's going to decrease the chance significantly of severe disease. Also, this new study lets me say it can decrease the risk of perinatal death for the baby if you were to get COVID, if you were unvaccinated, and decrease the risk of preterm birth. It also allows you to pass antibodies to the baby. I was far less worried about my daughter getting COVID for the first six months of her life than I was about my unvaccinated 2.5-year-old getting COVID because he didn't have any antibodies. And I try and really frame the conversation in in the way of protecting the family and protecting their family and what they care about, and decrease the risk of them getting COVID. And if they get it, decrease the risk of them transmitting it to somebody else in their family, and decrease the need for quarantine and isolation. For a lot of pregnant moms, I think during COVID, it was a really isolating experience. It was hard to feel comfortable congregating. I mean, it's still hard to feel, but like even with other vaccinated people, it was hard to feel like I can take on this additional risk until I was vaccinated, and that I could even see family and have people come visit the baby when the baby was born. But to know that the baby and I were both vaccinated made me feel a whole lot better about having family visit the baby, see the baby, all of those things, which can just be a very important mental health thing I think for a lot of patients and a lot of new moms. And I often use the phrase, we're trying to build a protective bubble around baby. And the bigger that bubble can be, the better for mom, and I think better for mental health. And so the more people around you can get vaccinated, I think the more people you can let into your circle a little bit more easily. And so sometimes really focusing on the protective element of it, rather than the risky element of it, which I think is what Twitter and all of the social media focuses on, really trying to talk about the protection for baby and for mom. All right, so bottom line, we need to all be working together across the state to increase this 40% vaccination rate in pregnancy. We should be asking every single patient we see whether or not they're vaccinated, and making sure that they all know that it is our medical recommendation that they be vaccinated. The number of patients we have transferred here who, some of it's definitely wishful thinking on their part, but say that they were not recommended to get it in pregnancy. I definitely don't believe it all, but I think there are certainly some people who are still hedging based on, initially there was limited data, but now we really do have good data, and we have good support for saying that this is definitely a strong recommendation in pregnancy. When you start these conversations trying to lead with curiosity and empathy, like I said, that 2 weeks in December where I was offered the vaccine and I didn't know enough yet if I should take it or not, were incredibly stressful. And so while I think it's fewer and fewer people who are at this stage of the pandemic and pregnant who truly just don't know, there are still some out there. There are some that I still see for their initial prenatals, and they're like, oh, I very genuinely thought this would cause infertility and hurt the baby. And I'm like, no, let's go through it all. And they're like, oh, okay, then I'll definitely do it if it's actually recommended and it's good. And simply haven't had a contact with the medical system in many parts of the pandemic. And so making sure that they know that this is our recommendation, and beginning the conversation with empathy and not with that accusatory tone that I think, unfortunately, some of our burnout is predisposing us to. And don't get discouraged. A lot of people are going to say no. A lot more people say no than say yes at this point, because most of the people who were inclined to get it already did. But just trying to roll with it and come back and try another day. And that yes often starts with a trusting therapeutic relationship. And so I think for a lot of patients, we're having to get there first and have that trusting therapeutic relationship before we can get the yes. And so I'm getting a lot more yeses at the end of pregnancy than I am sometimes at the beginning, because they don't know me, and they don't know anybody here in this office, because they're only coming because they're pregnant, and they might not have contact with the medical system outside of that episode. So sometimes stepping back and giving them a few visits and really trying to build that therapeutic relationship before we try and push much further can be beneficial. All right, and then just thanks for having me. Thanks for listening. I'm happy to take any questions. And Ellie is very thankful, even though she's out of her 6-month window, she's no longer vaccinated, but she's still perfect. And so the vaccine didn't do anything wrong except maybe make her sleep better, I hope. Any questions?
Thank you, Dr. Doorey. So if anybody has any questions, feel free to put them in the chat. And we will leave things open for a few minutes. So we have a question. Great discussion. Thank you for spending your lunch hour with us. What handouts do you like to recommend to send home with patients?
So I made my own dot phrases. We use Epic here. So I made my own dot phrases that kind of go through and pulled a bunch of the recommendations and whatnot. If I can certainly copy paste them into an email if people would like to see sort of the wording on them. I've got a couple different ones. One that goes through all of the COVID and pregnancy information, including primary prevention with vaccines, post-exposure prophylaxis with monoclonal antibodies and treatment with monoclonal antibodies. That being said, we don't currently have enough to go around. And so most of our pregnant patients are not qualifying right now for monoclonal antibodies. Right now, it's mostly cancer patients and people with severe immunocompromised states. So, but it goes through all that information. And then I have some that are just targeted on the vaccine itself. And I'm happy to share those if it would be helpful. And then also I've sent some people links to the CDC and places like that. But I think with the trust a little bit broken with the CDC for some people, that hasn't been quite as helpful. So I made my own. And so that's, I think most of my department's using mine right now.
There were several that said, please send those along. That'd be great if you don't mind sending to me, and I can respond to everybody that's on this email or on this call. Another question: if a pregnant patient chooses not to be vaccinated and acquires COVID and then decides to breastfeed, are they still able to transmit antibodies to their newborn?
Yeah, and if you get COVID during pregnancy, you do have that placental transfer depending on when you got COVID in your pregnancy. So there were a couple early studies. They were small cohorts in the teens, I think, but they looked at, and actually patients who got COVID in their first trimester passed more antibodies via the placenta than ones who got it later on. Theoretically, they had longer to transmit. But yes, then you can also pass them through the breast milk. The thing about the breast milk is those are mostly IgA antibodies. So they will coat the infant's mouth, oropharynx, and their esophagus. So if the infant breathes in COVID or gets it in their mouth at the time that those antibodies are still there from breastfeeding, they have a better chance of neutralizing them. But the antibodies are destroyed by the stomach acid. So it's not like you're getting systemic antibodies from the breast milk. So the breast milk antibodies are less effective than the placental antibodies, because then they have full circulating antibodies.
Anybody else with questions?
Well, and with that question, one where we've gotten a couple times was whether or not we're separating COVID positive moms from babies at this point. We are not, unless the baby needs to go to the NICU. But we are encouraging moms, if they have COVID and they deliver, to wear a mask. Direct breastfeeding is great because it will give, if they've only recently had COVID, they may not have had placental transfer yet, and then at least the breastfeeding will give them some antibodies. But we're not requiring separation, like I think was temporary in the very early parts of the pandemic when people were really nervous. Newborns tend to do pretty well. There is a small chance of placental transfer of the actual COVID virus, about 1 to 4% in some of the bigger studies. So some babies will be born COVID positive, and then some babies will convert. And so we're testing the babies before they go home as well to see if they have converted to positive. But for the most part, the babies are doing very well, even rooming in, as long as they're term and they're otherwise well enough to be in the room with mom.
I think that's a good add-on. I know that was to your point, different policies we've changed over as we've learned more. So, all right, I am not seeing any further questions. Let me make sure nobody has their hand raised. I do want to say thank you very much, Dr. Doorey, for presenting today. Very educational. And I'm sure everyone else thought so as well. Yes, there's thanks for the information. Thank you. Lots of thank yous. So
my email is on this slide. If anybody has any questions, I'll share with Shannon my dot phrases and feel free to use them. And if you have any additional questions, feel free to email me.
Perfect. Thank you very much. And for those next month, we're going to do impacts of COVID on our perinatal mental health individuals. So following right along with this, but that will be February 15th. So without further ado, thank you, everybody. Have a great afternoon.
Thanks, you too.
Bye.